Dr. Chris Gibbons is our next speaker. He is the Chief Health Innovator Officer at the Federal Communications Commission. He is a physician entrepreneur, health innovator, and academic physician with expertise in minority health, health IT, and health disparities. Previously, Dr. Gibbons was an associate director of the Johns Hopkins Urban Health Institute and an assistant professor of medicine, public health, and health informatics at Johns Hopkins University. He is a published authority, an international speaker, and he has authored over 75 books. Dr. Gibbons obtained his medical degree from the University of Alabama, Roll Tide, and then he completed his residency training in preventative medicine at Johns Hopkins. Dr. Gibbons also earned a Master of Public Health degree focusing in health promotion among urban and disadvantaged populations from Johns Hopkins. Ladies and gentlemen, please welcome to the stage, Dr. Chris Gibbons.
Thanks so much. Appreciate it. Good morning. Thanks for having me with you. It's amazing. I'm going to be talking to you from a different angle, but it dovetails very nicely with what the first two speakers have talked about. So why don't we get started? So I'm not going to spend a lot of time talking about disparities and the numbers. We've had two great talks doing that, and I figured at a disparities conference, most people coming already know that. So the first point is disparities exist. They are real. We're no longer living in a world where anybody who has credible information can deny this reality. We now at the national level, through the National Healthcare Disparities Report, have about a decade's worth of national data following and measuring disparities. Anybody know what's happening to disparities? Probably can guess by being here. They're intractable. They're not going away. Some years, some get better. Other years, those same things get worse. We're making no systematic improvement at a national level in any of the disparities that are measured at a national level. And that's almost the same true at the state level and local level, although not in 100% true, and you've heard about some of that. So in my view anyway, we have systemic failure to eliminate and reduce and keep reduced disparities. But before we go on, there's another reality, and the second point I wanted to talk to you about today is that the world is changing in some very fundamental ways that impact the world of disparities and everything else. We are virtually living. More, and you can take that two ways. Too many people are living in poverty, virtually living. But the world I'm coming to talk to you about today is that more and more of our lives, the lives of all of us, are being lived online. Whether the Pew Charitable Trust said it this way: the internet and broadband is changing everything about American life. It's changing the way we live, the way we shop. It's even changing the way we elect our presidents. And it is so true. Increasingly, everything you do and want to do in one way or another is going to be tied to the internet, to broadband, and some connected device. It's getting so prevalent that technology is everywhere, even among the poor, even among the disenfranchised. When I give talks like this, oftentimes people say, oh yeah, cell phones, they're everywhere. And that's great, they are everywhere. But there's a technology in this country that's even more ubiquitous than a telephone. Anybody know what it is? Just shout it out if you could tell. No idea? What's that? Television. The Nielsen Foundation tells us that there are TVs in almost 100% of households living in America. So when you combine cell phones and televisions, which are now converging, content that you can have on one, you can have on the other, and on tablets, it allows us to reach virtually everybody. There are homeless people with cell phones. There are people living under the bridge with cell phones. You've heard about the Obama phones. That's an FCC program providing funds for these things. So we have now, it's been estimated, John Chambers, who's the past chairman of Cisco, has estimated that by 2025, there will be over 500 million devices connected to the internet. Others have projected that we're getting close to the place where every individual will have at least 7 devices in one way or another connected to the internet. Right now, we're at the place, and that's globally. That's not just the United States. Right now, we're at 2 to 3 on average. But in some ways, the way I think about this, this could be a disparities game changer. And let me illustrate, because you probably may not see it. It's not just the devices, but the ability to connect through broadband, or what I'm calling broadband connectivity, that really can make the difference. Because you see, while having 500 million devices that can tell you everything about yourself or what you need or what you buy or where you go or things like that, and connecting with healthcare systems and connecting with whatever is fantastic and may make a difference in many, many things, not just health, education, and other ways, it's really not the devices where the power is found. Mark Weisner was a visionary computer scientist who died back a few years ago. But he said this: the true power of technology is not found in the device, but to the degree in which they become invisible and then weave themselves into the very fabric of everyday life. I think he's absolutely right, and saw what many even today still don't see. It's not about the thing you have in your pocket that you can do things, but as we move towards miniaturization and nanotechnology and things being built into things, that things can automatically happen even when you don't recognize what's going on. For example, how many of you drive cars that have power windows? Guess what? It's technology making those windows go up and down. You want to go back to the days when you're doing it manually? I see the head shaking. Right. We don't even think about the technology anymore. We press the button, the windows go down. We press the button, the windshield wipers go this way. The power of the technology, we don't even think about it anymore. It's about the networks that these things are tied to and the ecosystems that can be produced. That is where the real power is found. For example, we can now very soon connect everyone and anyone to anything they need, anytime, night or day, anywhere they are. You think about that potential. We're very close to that day right now. We can connect you to the systems you may need for your health, whether they're healthcare systems, whether they're social systems, whether they're educational systems, whether they're financial and economic opportunity systems. We have the ability to connect you to those systems. So we have the ability to connect you to people you may need. It could be professionals like doctors and nurses, but it could also be family members who live in other states. It could be caregivers within your community that help care for you. We have that ability. We have the ability to connect you to whatever information you might need in a way that you can understand it, not just in a way that I can understand it as a physician. By the way, AT&T has found a way to communicate your cell phone bill in whatever language you need in a way you understand, so you know how much to pay. So we can bring that into the health world. And finally, so with that, we may, for the first time in history, be living at a time where this issue of so-called hard to reach is off the table. There's no longer anyone that's hard to reach, because we have technological pipes to just about everybody. We still have to figure out what to do. But this idea, this excuse I often used to hear and still hear sometimes, the reason we can't do any better, because they're hard to reach. We are very quickly coming to a time where in this country and globally, nobody is hard to reach. In Bangladesh, in India, some of the poorest places in the world, they have cell phones, and it is attributed to raise the GDP and the economic and health well-being of the people living in those areas. And finally, as computers get more powerful, as they get smaller and their processing capacity gets better, we can put the chips right in the things, and that will then give them a sort of intelligence so they can sense something, make some calculations, and then do something without even the interaction of an individual, being a family member or a doctor or anybody else. If you begin to think that's powerful, you can understand, and it's already happening. There are glucometers, glucose meters right now that people have. They're already on the market. They take your blood glucose level automatically. Depending on what it is, it gives you the right dose of insulin you need based on your blood glucose at that time. No doctor involved. That's just one simple little example. But if you extend that to so many other things, what the power what could we have? So again, we eliminate the problem of hard to reach. Think about connecting people when they want to be connected, where they want to be connected with loved ones who live anywhere. Not just hearing them on the phone, but being able to talk to them in real time. What could that do to social isolation? What could that do to stress? What could that do to so many of the things that the other panelists before me have talked about? We're getting to the place where that's possible. It's absolutely possible. It even can change what I believe the social sciences itself. We talked about, Dr. Adams talked about, and our first speaker talked about bringing people to the table. And I've been a part of those efforts to bring people today because I believe that is the right thing to do in order to get in many different venues and in many different ways. But I can tell you from experience that sometimes we work so hard bringing the right people to the table that we never get anything done. Oh, I heard one person clap. You know, it's a nice motto, it's a nice slogan, and it's important. But making it happen, bringing somebody from out of poverty, that is in poverty or on the other side of the tracks, to sit down with others who might have the ability to do something and have meaningful exchanges is difficult. You have to build trust, you have to build willingness, you have to get over the history that's been there first before they'll even think that you're serious about wanting to help. And then maybe they'll come to the table. And then once you get to the table, well, is he telling the truth and fighting and back? I've been there. It's still important. We still got to do it. But guess what? We're living in a world where I can be anywhere in the world and still collaborate with you in real time. Why don't we bring that into community-based participatory research and health? Why do I have to be sitting at the same physical table at a time when it's convenient for you to be able to collaborate with you in real time? The truth is, I don't have to be. I collaborate with partners all over the world whenever it's convenient to all of us. We need that thinking to come here as well. And when we begin to bring this processing power and put it into these devices, they become intelligent and everything becomes smarter. That's where you get this idea of precision medicine so many are thinking is in the future. But I believe you can go beyond that. You can go far beyond that. We have to go far beyond that to where we can actually even alter or so-called treat the environments, the places where people live, and change the risk factors that they are under, and therefore eliminate risks and close disparities. And I'll give you some quick examples before I close. Imagine. I'll give you an example from infant mortality. Years ago, I was at Hopkins working on these kinds of things, and somebody, my boss, actually said to me, you know, we have a similar problem with infant mortality in Maryland and in Baltimore as you have here, and Tony showed you some of that data. Why don't you develop an intervention and see if we can't fix it? Now, I'm not a pediatrician, as you heard. I'm not an OBGYN. I know this problem is difficult, and many wise people have gone before me and been slayed at the altar of trying to fix this problem. So because I'm not in the business of failing, I didn't really want to do it. I'll just be honest with you. But they kept pushing. You're doing good work over here. Let's see if you can bring it over here. So studied this problem. And one of the things that came to my mind, a few years before that, we had developed a health worker intervention, community health worker, patient navigator, because I believe that's a model too that is important here. And they were focusing on, one of the things they were focusing on was birth outcomes. And I was at a meeting similar to this with other community health workers who were focusing on that issue. And I just remember sitting back and listening to them, and over 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 again, they were lamenting how, from their perspective, now that is not the experts' perspectives as you hear, but these community health workers who came from those communities, who lived in those communities, who grew up in those communities, they were lamenting that the reason, from their perspective, the birth outcomes were what they were and infant mortality was what it was, is because the young girls and the women who were getting pregnant were getting their information from the wrong places, and that they weren't getting good information. And I thought about that. I said, okay, I heard it so much. I finally got up. I said, okay, tell me, where do you see that these young girls in the inner city, and it could be true in rural areas too, are getting their information? Anybody have any idea what they said to me? This was a few years ago. And this was in Baltimore, so it was largely urban African American, but not only. So things have changed now, and you can kind of guess, but at that time, the number one place that these women said these individuals were getting their information from was MTV. You laugh, but I said, MTV? How is it MTV? They said there was a program on TV called Pregnant in 16. I had never seen it before. I'd never heard of it. I had to go to the internet. I had to look it up and watch a few episodes just to know what it was. And it was these early reality programs where they bring together dysfunctional girls and pit them against each other and show their woes and this kind of thing. Now, you can argue with it right or wrong, but their conception is that this is where these girls were getting their information about sex, about pregnancy, about life. And the other, number two place, the internet. blackplanet.org. The third place, radio, prominent radio hosts like Tom Joyner and other places. So it made me think years ago. Now, in public health traditionally and in medicine, we say, oh, stay away from the media, it's going to die. And I started thinking, but this is where people are. Like it or not, this is where they are. So one approach might be to think about how we can use these tools in the right way instead of just allowing them to be used in the wrong way and shake our hands and say, oh, it's a problem. So these got me thinking about it years ago. So then when I got pushed into doing this thing, again, it was another reason to try to blend technology and health and things like that. Make a long story short, we developed an intervention. We did a pilot study. We had about 800 women who were pregnant, inner city, low income, average age, I think, mean age was about 17, something like that. Go through this program. We did a quick analysis of about the first half of them. And interestingly, over this 2-year period, we were able to drop infant mortality rates in the African American community down to the national average. Well, we thought that was great, but then we started looking at some other things that were even more important and turned out to be more interesting to the healthcare system. I'll just tell you one. We found that, one of the biggest challenges is that many of minority babies need to go into the neonatal intensive care unit. That's an extremely expensive proposition. Well, we found that we were able to drop that rate down to about less than 2%, which just in the course of this pilot study, with half of the 800 women going through, we may have saved the hospital system over $2 million right there. And it turned a lot of heads, and it got a lot of people thinking. It got me thinking, not so much about the hospital system, but that this problem, there are things that can be done to this problem. Technology can be part of the solution, and we've got to think more about it. Let me give you one last example that's a little more future-oriented, but still possible today. I have two friends right now, childhood friends who are dead now. They both had asthma, and both of them died while playing outside on the basketball court, having an asthma attack, and could not get to their inhalers fast enough. Imagine for a minute that you have a child, or you're caring for a child that has asthma. But imagine we're living in this future connected world that I'm talking about, where we have those 500 million devices, where healthcare systems are not just connected to each other and the providers that provide care, but they're also connected to social care systems, and they're connected to smart homes, and they're connected to smart cars. You've heard about those things, right? They are there, and they are already talking about what we can do in the health realm. They're also connected to schools that are online and connected to job opportunities and things like that. So we live in this connected world. So this young person is sitting in his home and begins to have increased work of breathing. That means it begins to get harder to breathe. That usually happens before a frank outright asthma attack. But because now we live in this world, the sensors in the home detects the work of the breathing and says, oh, there's an impending problem coming on based on the algorithms that have been put into the computer systems that are on the network that run this system. And then automatically does a couple of things. Raises the humidity level in the room of the home where the young person is. Now, why would you do that? Well, if you go to the emergency room, what are they going to do? They're going to give you a nebulizer treatment. What is that? It's moist, humid air. That's what you're going to get with some medicine in it. And so the first thing it does before the frank asthma attack comes is raise the humidity level in the room that you're sitting. And then out of the vents in the floors or in the ceiling of the home, it automatically gives that puff of albuterol to the child that is having increased work of breathing, averts a frank asthma attack. That person just got health care and didn't even know it and didn't even do a single thing. That's where we are going. And that's just an example of something in a home where we modify the environment around somebody to change the likelihood of acute exacerbation of some kind. But think about what that's possible on the community level, outside the homes, and on and on and on. My friends, I think if we understand it, broadband connectivity, the ability to connect, can do so much more. It can eliminate the hard to reach. It can enable individualized health and care. It's not just about health care. It can enhance personal supports. It can alter social and environmental risk factors, and that's why we've actually begun to call broadband connectivity an upstream, a new upstream social determinant of health, because it impacts so many other things. It can also promote economic and educational advancement, and as we do these things, I believe we have the potential to make a serious impact in disparities in health and beyond. Thank you very much.
Thank you, Chris.
Is that all right?
Really appreciate your passion on the subject, and this is not a plant. I've spent 40 years carrying this around right next to me.
There you
and
go.
I was that kid on the basketball court who barely made it back in time. So I can't wait for that day to come. And I know that there's apps out there. We need to increase the availability where we were all taught to do our peak flows.
Yep.
My nephew has asthma. He does his peak flows every day. We need to be able to have a system where you can plug it in and get instant feedback, because a lot of times the peak flows start to go down before you even perceive that you're having trouble.
Absolutely.
So a couple of quick questions for you that I think are important for this audience. The answer that you get so often is, okay, well, that's all well and good for the big guys, for the big institutions, for the people with the money and the infrastructure.
Right.
We've got a lot of community groups here, a lot of small local health departments. Can you give some concrete examples of where they can integrate technology into what they're trying to do?
So first of all, that's why I started with sort of the technology ubiquity, to let you know that technology is not just in the hands of the rich. It's not just in the hands of the middle class. It's actually also in the hands of the poor. Now, do we have a problem? Is there a disparity? Yes. The recent numbers at a national level tell us that about 95% of the population has some access to some form of technology. And you might say that that's pretty good, especially after what I just talked about. But from my perspective, that's not good, because with 320 million people in this country, it's about 322 million now, 5%, about 16 million people. You know, that's a huge number. It's too many. It's way too many. So we've got to change that, and that's one of the things we're working on, trying to bring about at the FCC. And so the There are many ways, potentially. I also alluded to the idea of community health workers who work in lower income communities. One of the reasons I started that program many years ago was not to do yet another community health worker program, but the idea is once you establish a good health worker program in low income communities, if you then embed technology with them, what they're able to do might exponentially increase in these populations. I think there are many ways to look at it. It's not just how do we get another piece of technology in somebody's hands in order to make a change in an outcome. There are many levels from the, the individual level, the community level, the society level, other levels that we can think about technology and how it might help. But I'll stop there.
One last question for you. I'm a big believer in data.
Yep.
But data is power and data is money. Mm-hmm. And one of the frustrations that a lot of the smaller people, smaller groups, smaller community organizations have is you've got the big insurance companies and you've got the big hospital entities, and they have all this powerful data, but they don't want to release it to the community groups and the people doing the grassroots work because that data is money. That data is power. We got Dr. Eiten and I were at the ASTO meeting, and there was a wonderful presentation from a gentleman from Anthem about how he could go down to the block level and show you all the risk factors. And then afterwards we said, well, how do we get that data? Well, you've got to pay for it.
Yep.
Because that's Anthem's data.
Yep.
So what is the FCC doing? What can we do so that what you're saying is not just a pipe dream, but there's actually a free flow of that information from the people who have it to the people who need it?
So I think this is, again, another example of how technology is so powerful. So you're right. There's a lot of, hospital health systems want to control that data. Even public health systems want to control that data. But that's why, but patients, first of all, they already got their own data, number one. It might be nice to have that, but they know what's going on. And if they don't, that's why Dr. Google has become so important, right? I'm not actually joking. The number one health search topic on Google now is about health. It used to be pornography, but now it's health. I'm also telling the truth about that as well. People are not able to get what they need out of a health system, so they're going other places. So, I'm a bit of a contrarian on this, even though I'm a physician. I'm like, go ahead, fight over your data. The consumers are going to go wherever they need to go to get the data they need, to get the help they need to solve the problems they want to solve. It's up to us to decide if we're going to be a part of that, or it's going to be social entrepreneurs and others on the outside who recognize consumer demand to supply that need.
So we've got some big hospital systems here too. What's your message to them then?
Well, I'll put it to you like this. Again, John Chambers, I referenced him in my talk at a global technology forum that Forbes put on just a few weeks ago. He said, look, in every industry, the major dominant players, if they don't understand this change that I just described to you, particularly the impact of the Internet of Things on life, and he wasn't just talking about health, he was talking about everything. I believe 40% of them will not exist in any meaningful way in a few years, and they risk becoming totally irrelevant. How many of you have heard of Woolworth and Wilco? Yeah, where are they now? They were the dominant department store chain for many, many years. They thought no one could do it better than they could do it at a cheaper cost than do, or that no one would ever go anywhere else. Gone. The same thing will happen in healthcare, in public health, wherever, unless we recognize this. I'm not talking about something we need to create. It's happening before us already. This is where people are, and if we still try to use public health ways or medical ways of the past, when we went to medical school to make change, whether it's the disparities or other ways, it will continue not to work. But that doesn't mean the public will stay waiting for us. They'll go and find their solutions their way.
So my challenge to the hospital systems and the big groups that are here is this afternoon, find someone in your community to partner with to do a community needs assessment, figure out a big problem in your area and try to find a way to harness technology, maybe come up with an app for infant mortality or asthma or hypertension or whatever is the predominant problem in your area, because we've just heard that it's possible. We just have to get the right people to the table and decide to do it.
And you've heard from the other speakers, I echo all of that. I just left it out because they said it and need to. You got to involve the people. You've got to involve, in the computer world, we talk about end users. In medical care, we talk about patients. In the rest of the world, they talk about consumers. consumers, patients, end users have to drive it. It cannot be the experts sitting back. We as doctors think we know something about patients, what they want and what they need, and that's true. But every time I begin to ask, and I've done hundreds and hundreds and hundreds of focus groups and others on these talks with African Americans, with Latinos in Miami, all over the course, I inevitably learn something I didn't know. I suspect that others would have the same experience.
Thank you so much, Dr. Gibbons.
Thank you.
Appreciate it.